Now that you understand the criteria for assessing lens diameter, let's move into the practical application we discussed earlier. These are all real-world clinical cases. Let's begin by examining the first 10. As a reminder, lenses with excessive sagittal depth, resulting in a tight or high fit, are easier to assess. They move less, center well, and display clearly visible edges. We will focus primarily on shallow fits, as these present a greater challenge for diameter evaluation. You will now be presented with some videos. Your task will be to assess whether the lens diameter corresponds to the corneal diameter and, if not, decide exactly how it should be adjusted to optimize the fit. The correct answer will then be provided, along with a clinical explanation. As a reminder, the diameter should be evaluated primarily along the smaller, the vertical, meridian. The desired limbal gap is 0.4 mm, meaning that the total limbal gap along each meridian should be 0.8 mm. That is, 0.4 mm on each side. For elliptical corneas, you will often need to deviate from this standard. The 0.4 mm width of the lens edge can be used as a visual guideline to judge the limbal gap. What do you think of the diameter of this lens? What is your proposed action? The diameter of this lens is too large. In this case, we must reduce it by 0.4 mm and re-evaluate. Looking at the vertical meridian, the lens is impinged on the limbus at the bottom, while the gap at the top is too small, only about 0.1 mm. If we were to forcibly center this lens, it would rest touching the limbus at both the top and bottom. To achieve a safer, reasonable gap of 0.2 mm in these areas, a total diameter reduction of 0.4 mm is required. But what happens to the horizontal meridian? Currently, if the lens is forcibly centered, there is approximately 0.2 to 0.25 mm clearance on each side. By reducing the total diameter by 0.4 mm, that horizontal gap increases to roughly 0.4 mm per side, which, when combined with a reasonable gap along the vertical meridian, is perfectly acceptable. What do you think of the diameter of this lens? What is your proposed action? Although the eye is poorly lit, we can clearly see that the lens diameter is slightly too small. To achieve a better fit, we should increase it by 0.2 mm. In the vertical meridian, the current limbal gap is adequate and is large enough to handle a slight reduction. However, in the horizontal meridian, it is slightly larger than required. Since the gap along the vertical meridian allows the diameter to be increased, it is better to do so to avoid possible lateral decentration. What do you think of the diameter of this lens? What is your proposed action? In this case, the diameter is too large. We will first reduce it by 0.2 mm and then decide if a second 0.2 mm reduction is necessary based on the resulting limbal gap. This cornea is highly elliptical, as the horizontal diameter exceeds the vertical by 1.3 mm. Currently, the vertical fit is problematic. The lens practically touches the limbus at the top and overlaps it at the bottom. The gap along the horizontal meridian is normal, as the sum of the left and right sides is approximately 0.9 mm. While theory suggests a full 0.4 mm reduction, doing so would create an excessive horizontal gap of 0.65 mm on each side, which could trigger significant lateral decentration. By starting with a 0.2 mm reduction, we hope to achieve a minimal vertical limbal gap of at least 0.1 mm per side. If limbal touch persists, however, or the patient's vision is undercorrected, a further 0.2 mm reduction will be necessary. It's important to note here that if this results in pronounced lateral decentration and the patient consistently complains of halos or double vision, it is possible that they may wish to discontinue the treatment. Ultimately, the patient would need to decide whether these visual imperfections are acceptable in exchange for the therapeutic benefits of the lenses. As discussed in Part 2, fitting noticeably elliptical corneas requires a delicate clinical balance. On one hand, a diameter that is too large relative to the vertical meridian and can lead to undercorrection. On the other hand, if we reduce the diameter too much, the lens becomes too small relative to the horizontal meridian, potentially leading to lateral decentration. What do you think of the diameter of this lens? What is your proposed action? In this case, the lens diameter is adequate. The total gap along the vertical meridian is 0.5 mm, which is below the target value. However, the total clearance along the horizontal meridian is 0.8 mm, which exactly meets the standard. Under these conditions, where the horizontal fit is perfect, a total vertical gap of 0.5 mm is acceptable. Keep in mind that lateral decentration does not have to hinder your diameter evaluation. Simply use forced centration in your mind's eye. Mentally shift the lens to the center and visualize the resulting distance between the edges and the limbus. With a little experience, this mental alignment becomes second nature. It is also worth noting that an excess of fluorescein makes evaluation more difficult due to reduced image contrast, making it harder to distinguish between the limbus, the transparent part of the cornea, and the edge of the lens. Also, observe that while the lens shows pronounced lateral decentration, the pupil is also slightly decentered in the same direction and actually coincides with the area of central bearing. This is a fairly common situation, so before you get overly concerned about a lens displaying lateral decentration, check the position of the pupil. What do you think of the diameter of this lens? What is your proposed action? The diameter is slightly too large. The total gap at the top and bottom is 0.15 mm, meaning that the lens is almost touching the limbus. At the same time, the total horizontal clearance is 0.7 mm, so slightly below target, which would be acceptable if the vertical clearance was adequate. Given the insufficient vertical gap, the diameter should be reduced by 0.2 mm. What do you think of the diameter of this lens? What is your proposed action? The diameter is slightly too small. Along the vertical meridian, the total gap is 0.8 mm, exactly as it should be. However, along the horizontal meridian it is 1 mm, which is slightly above the desired value. Since we have enough room to expand vertically, we should increase the total diameter by 0.2 mm. This would result in 0.4 mm of clearance on each side horizontally and 0.3 mm at each side vertically. Note that this video was recorded in such a way that the top and bottom edges are not simultaneously visible. It is fairly simple, however, to extrapolate the hidden portion by assessing the visible one, and therefore estimate how far the lens edges are from the limbus. What do you think of the diameter of this lens? What is your proposed action? In this case, the diameter is at the upper limit. The correct course of action is to leave the diameter as it is for now, but to be prepared to reduce it by 0.2 mm if undercorrection is observed. This cornea exhibits noticeable ellipticity. Vertically, the clearance is minimal, approximately 0.15 mm on each side. Meanwhile, the total horizontal clearance is 1 mm, which is slightly above our target. Reducing the diameter might lead to lateral decentration. This scenario is similar to video number 3, but with one critical difference. Here, the lens is not touching the limbus along the vertical meridian. Therefore, we should maintain the current diameter. However, if the patient shows an undercorrection despite good centration and a plano-over refraction, then a further reduction of 0.2 mm will be required. What do you think of the diameter of this lens? What is your proposed action? In this case, the diameter is at its upper limit, and we should reduce it by 0.2 mm. You'll notice that the cornea here is less elliptical than in video number 7. The total gap along the vertical meridian is 0.35 mm. This is borderline, just at the minimum acceptable threshold. Meanwhile, the total horizontal gap is approximately 0.7 mm, which is slightly below the ideal standard of 0.8 mm, and we have the margin to reduce the overall diameter. A 0.2 mm reduction would be justified in this case. What do you think of the diameter of this lens? What is your proposed action? At first glance, the lens might appear small, but the diameter is actually appropriate. No changes are necessary. This is a very round cornea. The total clearance is exactly 0.8 mm along both the vertical and horizontal meridians, providing a consistent 0.4 mm gap on all sides. Since these measurements equal our desired values, the diameter is considered ideal. Note that the practitioner is not holding the eyelids in this video, which makes it more difficult to evaluate the diameter. This approach is not recommended. What do you think of the diameter of this lens? What is your proposed action? In this case, the diameter is slightly too small, and we should increase it by 0.2 mm. This is a rare case. The cornea is nearly round, and it appears that the vertical diameter is slightly larger than the horizontal. We see a total vertical gap of 1.1 mm, while the horizontal gap is 0.9 mm. Both values are above our 0.8 mm target. Increasing the diameter by 0.2 mm will bring the horizontal gap to a perfect 0.7 to 0.8 mm, and the vertical to a safer 0.9 mm, providing much better stability. Note that the excessive amount of fluorescein interferes with the evaluation. Fortunately, the lens centers well on its own, making it easier to assess.